asking me to talk. I'm really delighted to speak to you guys, and I know a lot of you have experience in this area, and particularly in the kind of design of kind of big QI/research projects. So I'm really happy to kind of take comments and questions along the way if Zoom allows, or text comments, or we can just have a chat at the end. But Matt's asked me to talk about a project which we've been doing for the last 4 or 5 years now, I suppose, and I've called it Turning the Tide, which I hope will become a bit more obvious a bit later on, but hopefully going to pick out some lessons that we've picked up on, particularly around engagement and driving change. In terms of declaration, so I've received honoraria for providing education for Edwards, and also consultancy recently for the Covent project. So this picture is from 1954. The surgeon's name is Joseph Murray, and this is the picture of the first successful kidney transplant, as far as we know, which was done in Boston, and it was from one twin to another. And I've taken the liberty of highlighting the anaesthetist in the corner here, who don't know what he's doing, maybe some Sudoku or something. And I've put a monitor there just to make him look like he's busy monitoring the patient. But I think it's fair to say that transplantation's become the treatment of choice for patients with end-stage kidney disease, and certainly offers a mortality benefit over dialysis. But that mortality benefit only comes after the first 3 months post-transplantation. And so we know that the perioperative period carries significant risks for these patients, which we'll discuss. And if you look back at the research actually over the last 50, 60 years since this picture in 1954, actually not that much has changed. And there's a large amount of variation in practice. And even if you go from one end of London to another, so you take from the Hammersmith to Royal London, or the Royal Free down to Guy's, there's a big variation in, for example, how much fluid is given, what fluid is given, use of inotropes, diuretics, do we put arterial lines in, do we not? And there's a real lack of consensus amongst the transplant community. However, what you will see in most places is this practice of hypervolemia, on the premise that you can drive the new kidney to start working by essentially flooding it, and thereby kind of avoiding delayed graft function. This kind of flies in the face of the evidence from other major surgical specialties, which I'm sure you're well aware of this concept of optimizing hemodynamic therapy, or goal-directed hemodynamic therapy. And it's what I'm going to talk about today, is how we merged the current evidence that we know from other surgical specialties into this quite well-held belief around hypervolemia. The project really is a success story, and hasn't been without its bumps in the road. And I'm sure that you have been involved, as I have, in many projects along the way, where you start off incredibly enthusiastic and a huge amount of energy, and it just, for whatever reason, peters out. Either you move on to another hospital, or things move on, and you might, if you're lucky, get a line on your CV. And this is an example of a project that wasn't like that, but they're few and far between. And hopefully I can kind of share some of the lessons that we learned in how we've come to where we are today. I'm sure I don't need to tell you from your day-to-day clinical practice that patients with end-stage renal failure are incredibly comorbid. They're almost all hypertensive, often diabetic. You can see here from this study in 2015 that up to a quarter of these patients have ischemic heart disease, and I think it's probably even more than that, but it's undiagnosed. So these are patients who all have kind of deranged physiology already. But there's ample evidence that for patients with end-stage kidney disease who are on dialysis, transplant is very, very effective. There's a huge mortality benefit, and it's also cheaper. It's cheaper to transplant someone than to keep them on long-term dialysis. And this is a really, this is the biggest systematic review, which was published in 2011, looking at odds ratios between transplant and dialysis. You can see from on the left here that in almost all outcomes, the transplant is favoured, ischemic heart disease, heart failure, MI. And I like this one because actually functional status improves as well. The patient's mental state improves, their ability to work improves, so they're often become productive to the economy again. There's this nice kind of term of vitality, but actually their fertility also improves. So particularly women become fertile and men become fertile. So there's a great benefit to the population at large. So transplants a good thing. Here's the latest data published by NHSBT. So here's the Royal Free on the right here. So we're one of the smaller centres, although large by population served. So in the year to end of March 2020, bearing in mind that the programme stopped pretty much at the beginning of March, we did 123 transplants. So of those, 38 were living, 31 were DCD, and 54 were DBD. And the transplant program stopped until about July time. And in fact, in August, we did 5 pairs of living kidney transplants, which were the first ones done in London post-COVID. And the rationale behind stopping was that even though patients on dialysis were more likely to catch COVID because they were exposed when they went to dialysis, if you catch COVID having had a transplant because you're immunosuppressed, your outcomes are worse than if you hadn't had a transplant. So that's the rationale. So just a little bit about the impact of the anaesthetic. I'm sure many of you are familiar with this, but it's well established that the function of the kidney, the new kidney, is dependent in part on the optimized fluid hemodynamics. So the anaesthetist has a big role to play in the success of the operation. It's worth remembering that a transplanted kidney is denervated, so it can't auto-regulate as a native kidney will. But also that there's this kind of this narrow margin between giving too much fluid and too little fluid, and this well-presented graph showing there's a kind of sweet spot at the bottom here between fluid administration and complications. And when it comes to transplant, you're risking delayed graft function or worse still, a failed graft, against the complications of giving too much fluid, which are multiple. You can damage the kidney itself. You can cause pulmonary edema, cardiac failure, ileus, tissue edema. But the particular challenge, I think, with a kidney transplant is that the assessment of fluid status is much more difficult than in other major surgical specialties. As we've said, the patients have deranged physiology, so they don't. I'm sure many of you have done a kidney transplant or treated these patients. They don't react normally. It's quite common to have a patient with a blood pressure, with a systolic of 220 in the anaesthetic room. It then plummets and then goes back up. These are difficult patients to treat. They've usually been dialyzed when they come to their transplant, and you have to kind of take a guess a little bit about where their patient are, where the patient is. Are they dry weight? Are they a little bit over, a little bit under? As we said, there's a high incidence of cardiac disease, but also our normal endpoints of fluid status aren't there. We can't rely on urine output clearly. So it's a challenging anaesthetic, I think, and a challenging operation. But if you get it right, the anaesthetist really has a critical role to play in the success of the operation. So let me start telling you the story. So up until about 2018, this was the transplant protocol at the Royal Free, and in common with other parts of the other centres, we basically flooded the patients. We gave 20 to 30 mils per kilo per hour of a balanced crystalloid, guided by CVP. And I don't need to tell you say much more about that, and with non-invasive blood pressure. And the surgeons really would get quite upset if you put an arterial line in unless you had a good reason, because they had this worry, or they have this worry, that if you put an arterial line in, you risk or you compromise a future fistula. I don't think it's as much of an issue as it's played out to be. However, although many concerns about this protocol, lots of kind of mumbling in the anaesthetic room and in the coffee room, that first of all, we're giving huge amounts of fluid, which risks the complications that I've discussed before, and also the fact that we're using non-invasive blood pressure monitoring means we may well be missing episodes of hypotension. So how did I get involved, apart from mumbling about the fact that we're giving too much fluid? Well, first of all, I became PI of Optimize 2, and Optimize 2, I'm sure you're familiar with, is a goal-directed fluid therapy trial in major abdominal surgery. But we had access to the Edwards EV1000 device, and we just started chatting about how we could apply the device, and as I'd say, as a department, we became very familiar with this concept of goal-directed therapy. And it came to a day in interventional radiology, a long case. I was sitting with Jez Fabes, a colleague who many of you will know, and we just happened to be chatting about this. It just struck us that the kidney transplant patients, for the reasons I've stated already, would be the perfect patient group to look at the impact of a goal-directed fluid therapy protocol on. I've kind of simplified the story a little bit, but that's kind of literally how it started. So this is back in 2016. So as with all good projects, we started with an audit, because, you know, how do you know where you are? How do you know what you're doing? How do you know how well you're doing compared to your peers unless you collect the data? And this data wasn't routinely collected. And so using a combination of various databases and notes reviews, we looked at 41 transplant patients from 2016. We collected data about the recipients, about the donors. We collected data from the anaesthetic charts, and we looked at post-op complications and creatinines over the short and medium and long term. And what we hoped this would do is provide us with the kind of burning platform to start the project. So here are the results of that audit. So this is a year's worth of data. Demographics are kind of unremarkable, but let me point out the salient points here. So first of all, our median volume of fluid administered was 4.2 litres. So that's a lot of fluid for you know, a kind of 3-4 hour operation. Of that, 22% was normal saline, which is concerning, which was concerning, I just picked out here the exposure to intraoperative blood and the rate of pulmonary edema, which we thought both pointed and hinted at the fact that we were definitely harming some of these patients. There was iatrogenic harm from hypervolemia. And if you consider that a blood transfusion is pretty much like an organ transplant, there we were exposing 10% of our patients who were already immunosuppressed and having one organ transplant to another organ transplant from another donor. So that's not good. Also, just note here that the exposure to vasopressor was 63%. So not only were we giving lots of fluid, we were also squeezing these patients. So we presented some of this data to the department and to the surgeons and nephrologist, and they said, well, where are we? Where are we in the country? Are we an outlier? Unfortunately, I have some very productive colleagues, and meanwhile, whilst we were doing this audit, Claire Morcaine, who I'm sure everyone knows, and Jez and colleagues did a national survey of practice, which you can read, and it basically said that we were pretty much in the middle. We were doing, with some centres were doing stuff slightly differently. Some centres give mannitol, furosemide, dopamine, put arterial lines in, but we were pretty clear that the royal free practice was about in line with national practice. So this really gave us the burning platform to start developing this protocol. And it was, as I say, this access that we had to the Clearsight device, which was the kind of key to the success of this protocol development. As I said, our surgeons don't like arterial lines in, and so we had the benefit of the Clearsight device, which is non-invasive. It gives beat-to-beat blood pressure monitoring and enables, through the provision of cardiac output variables, goal-directed fluid therapy. I should say that the trial was supported by Edwards, but they didn't have any influence over the trial design or the results. When I say trial, it was a pilot rather than a formal research trial at that stage. For those of you who may not be too familiar with the Clearsight device, just very briefly, it's the PENAS technique, which you'll remember vaguely from your primary days, uses the volume clamp method. Here, it's almost without complication, I'd say. It's relatively simple to use. It's a little bit fiddly. Sometimes the doesn't pick up readings properly, or it's quite prone to interference. But by and large, I'd say 8 or 9 times out of 10, it works really, really well. In the same way as the FlowTrack or the LIDCO or the PICO, it derives cardiac output variables by looking at the area under the curve of the arterial waveform. And so the screens here that you get look almost exactly the same as if you had an intra-arterial catheter in. And in fact, you can transduce the arterial waveform onto the anaesthetic machine. And so for someone just walking in, it looks like you've got an arterial line in. So it's a decent bit of kit. So just to carry on the story, so we first had to jump a few hurdles. So we had to apply to the Clinical Consumables Committee to get that approved. And then we looked at the literature to see if we could follow or copy another goal-directed fluid therapy protocol. And we found that there isn't one or wasn't one for kidney transplant. And so it was a case of adapting it from other specialties. But here was the critical thing that we had to do, which was, Jez and I were very kind of committed to it. We were very energetic, but we really needed to get the agreement of the people that mattered. So we had spent a lot of time working with surgeons, with the nephrologists, with other anaesthetists, and that leads me on to my first lesson, and I'm willing to take a bet that no one's had a picture of Kim Kardashian. Matt, is that right in any of the presentations? And Selena Gomez, who here, I'm sure some of you will know, had a kidney transplant from her friend Francia Reiser here. But the lesson here is influencing the influencers. So what does that mean? That means finding the people that are going to make the difference to your project. And that's the people that are both going to make the success of the project, but could potentially stand in the way. And there are many. Because to make change effective, you have to be able to bring people along. Doesn't mean that you need wholehearted kind of support from the beginning, but you can't be an island. We were very mindful of the fact that we were challenging long-established practice. The protocol that I showed you in various guises had been in place for 10 or 15 years, and I think a certain degree of humility was required in order to set about challenging that practice, because people don't like change. That's one of the other lessons. So in this case, our influencers were the nephrologists, the surgeons, and that's particularly important since it's their name at the top of the bed. And I think we have to be mindful of that. And in particular with transplant, their name is not just at the top of the bed, but it could be at the top of a PowerPoint presentation nationally. Clearly, we needed our colleagues, other anaesthetists on board, managers, but also patients. And we engaged a lot with patients. And I'd say one of the lessons I've learned is how powerful patient engagement can be. We've had some patient engagement events and taken quotes from it, and really, really is helpful to involve patients early on, and they're really motivated, especially transplant patients. They're so grateful for the care that they've received. They're only too happy to come along to events or to join in. So that's lesson number 1. So April 2018, we introduced the protocol, and some of you will be familiar with this QI concept of the PDSA ramp here on the right-hand side. And what that points to is that what we really didn't want to do was make a big bang. This isn't a project, or very few projects work if you introduce, on a Monday morning, every single patient will have the new protocol. And there's this kind of tenet in QI that small cycles of change build confidence. We've certainly learned that along the way. But also it's really critical is education. And we spent a lot of time on education and spreading the word. And that brings me on to lesson 2, which is you have to spread the gospel. You have to spend the time educating the masses. And particularly for this, which was a real awareness for us that the protocol would not only be used in the middle of the day by an experienced consultant, but we needed it to be used in the middle of the night by a fairly junior registrar doing their first kidney transplant. And in order to give them the confidence to do that, we had to spend time doing education. So we did a mix of things. We did kind of T-trolley type education from theatre to theatre. We made sure that trainees were exposed to renal transplant lists during the day. We did presentations. We went and presented not only to the anaesthetists, but to the renal transplant physicians, to the surgeons. So really spent a lot of time doing that. And if I had my time again, I'd say we need to spend even more time doing that. And clearly along the way, you're going to meet people who are very enthusiastic, the early adopters, the late adopters. But it wasn't all smooth sailing. And I wish I could show you some of the texts I had a look back on when I was preparing this, particularly from the surgeons saying, Mark, I need a word. We did a transplant last night and so only gave so much fluid or gave too much fluid or whatever it was. And, I'd kind of lie awake at night worrying that, that someone could come along and just trash the project, go, no, we're going back to the previous protocols. So I think at this point, we're very invested in it. And the success at that point was working really hard and taking feedback. I'll talk through the feedback now because I'm just going to give you an example. And this was our first protocol that we instituted. It's very simple. We chose to use only 2 variables from the Clearsight, the stroke volume variation as a marker of kind of preload, I suppose, or your position on the Starling curve, and map. There are 2 sides to the protocol. So on the left-hand side here, if the stroke volume variation is less than 11%, in other words, we think the patient's euvolemic. We then look at the blood pressure. If the blood pressure is low, we ask the clinician to give ephedrine and then phenylephrine. Or if the blood pressure is normal or high, just to continue and do another hemodynamic appraisal. If on the other side of the protocol here, the SUV is high, in other words, the patient may well be hypovolemic, the clinician's asked to give a fluid bolus and then to reassess. Was that a question? Sorry. And in the background, there's fluid maintenance running. So this was our first protocol, and we very quickly got feedback that on the blood pressure aspect. So colleagues were saying to us, what does the baseline blood pressure mean? Is it the blood pressure at dialysis? Is it the blood pressure on the ward? Is it the first blood pressure in the anaesthetic room? What does that mean? So pretty quickly we changed the protocol to a MAP target. Now there are various, there's very, very little evidence in the literature around the correct MAP target for renal transplant, not forgetting that you're essentially targeting a map not only for the recipient but also for the donor kidney. And it would be wonderful if you could have a individualized map target for each donor kidney, but in practice that's almost impossible to achieve. So this was our second iteration. And really, the really important thing that we were doing all along was we were collecting data and real-time data and analyzing it in real time. And that's my third lesson, which is it is all about the data. And I'm sure all of you will be familiar with Deming, who's the kind of god of QI, who says, "In God we trust, all others must bring data." The data is absolutely crucial. And that was really, in particular with the surgeons and the nephrologists, what drove the success of the project, because the stakes are high. You know, each transplant is reported nationally. If things go wrong, not only is that you know, kind of investigated internally, but that's investigated on a national kind of public scale. And what they asked us, what they really wanted to know is, are we harming the patients? And through our collection of the data, we were able to show pretty quickly that we weren't, at the very least, we weren't harming the patients, non-inferiority. And that was, I think, that was a real kind of turning point in the project in terms of building up confidence amongst colleagues. So here's 3 kind of formal data sets that we collected showing percentage reduction. It's a bit confusing. A line down is good in this case because it's percentage reduction in creatinine. But here we're able to show that there is really no difference in creatinine reduction, which is what you want to see following transplantation, amongst the standard of care previously and our first and second Clearsight cohort. So that was a real turning point. And just to show you a little bit more data from our kind of cohorts here, this was the success of the project. Again, not only were we showing that we weren't harming patients, but we were showing that we were actually benefiting patients. So here's fluid volume. So this is in mils per kilo per hour. This is our standard group, and this is our first and second cohorts. A significant reduction in fluid volume administered intraoperatively from a median of 4.2 litres to just over 2 litres. As a result, there was less weight gain, as you can imagine, and less pulmonary edema, less post-op ileus, and earlier mobilization. And actually, I remember very clearly from one of our patient engagement events, one of the patients said, who'd been exposed to the previous protocol, that he woke up on day 1 and I quote him, "My balls were the size of watermelons and I couldn't get out of bed." And I'm sure that the early mobilization was down to giving less fluid. But interestingly, also, not only were we giving less fluid, but we were giving less vasopressor. And what's interesting about that is I think that was a real signal that this was not just about the machine, the Clearsight, wasn't just about the protocol. It was about the whole package. It was about education, and it was about educating people about flow and about pressure and the value of following a protocol, reducing variation. So this was really nice to see that we were giving less vasopressor. However, even though our results were good, we were still getting feedback from the surgeons that we weren't giving enough fluid. They were very nervous that we'd dropped down from 4.2 litres to 2 litres. And what they wanted to see was that more fluid was being given. And so we adapted the protocol to the current protocol to include a 500 ml fluid bolus in the anaesthetic room, which is actually really quite effective. It kind of levels the playing field between those patients that have been just dialyzed and those patients who were dialyzed 2 or 3 days before. And also we lowered our stroke volume variation target to 10%. So that's kind of forcing people to give more fluid. And I am really proud to say that now, as of today, pretty much every patient at the Royal Free having a kidney transplant is managed according to this protocol. And it's now the surgeons who are asking for the Clearsight. and making sure that the protocol is being followed. And that's really very pleasing, because we had a lot of resistance at the start. So just to finish off the data section, here's our kind of overall results of the project up until about 6 months ago. So we've significantly reduced the amount of fluid that we're giving. We've reduced the amount of vasopressor, pleasingly reduced the amount of sodium chloride that we were giving, and also the amount of blood products that we've been administering intraoperatively. And patient outcomes have improved. So there's almost no pulmonary edema now. As I said, blood transfusion up to 72 hours has reduced. There's significantly less post-op ileus, and patients are getting out of bed earlier. So that's the success story. Which brings me on to lesson 4, which was an opportunity for me to shoehorn in a picture of the best team in probably the world. You can argue with me if you want. But this is all about the team, and I'm going to name check people at the end, but this for me was a lesson in leadership, a personal lesson in leadership about how to lead quite a diverse team, and not only the team of anaesthetists, but the wider team of surgeons and nephrologists, nurses, patients. It's been a real team effort. So just in terms of what happens next, so we still continue to collect data and to improve the protocol. We've got a proposal drafted for an RCT, and having presented some of this work nationally, we presented the British Transplant Society. We have 5 other centres interested in collaborating with us. Chris Parnell, who's on the call today, is working with us now to extend the protocol beyond the operating theatre, so into the enhanced recovery environment. And what we're hoping to do is build a national consensus around enhanced recovery and goal-directed therapy. And we've penciled in a meeting in June through the AAGBI to try and achieve this. But here's the elephant in the room, which is COVID. So as I'm sure it's affected many of you, if transplant stops again, then our project's going to have to stop. But for now, we're cracking on. So just to name check kind of key members of the team. So Jez has been a massive part of the team right from the beginning. Also our other Periop fellows, Dina Hadi, Shan Butley, Aman Sana, Sak Naji, and Chris Parnell, who's just joined. And then my colleagues, Pete Berry, who's the renal transplant lead, Neil Banger, who's the transplant surgical lead, and Gareth Jones, who's the transplant nephrologist. So again, a huge team effort. And that is it. Thank you very much.